you
This
asking for?
conference will now
I was
be
asking
recorded.
Causely if he had fixed his mic. Okay, we are recording now. So AnCan is grateful to the following sponsors for making the recording possible. They are Bayer, Foundation Medicine, Janssen, Myriad Genetics, Novartis, Telix, and Blue Earth Diagnostics. We are also grateful for any of our attendees or members or visitors who would like to support the group here. We do have paid employees who assist in getting our newsletters ready and out on the time and reaching out to the community. So if you appreciate the work, help support it. AnCan respectfully notes that it does not accept sponsored promotions. Any drugs, protocols, or devices recommended in our discussions are based solely on anecdotal peer experience or clinical evidence that we may find in publications. AnCan cannot and does not provide medical advice. We encourage you to discuss anything you hear here in our sessions with your own medical team. So that's the disclaimer stuff. Good evening, Rick. Glad to have you on board, and good evening, Jimmy. Jimmy, are you going to need some time this evening?
I think I would take a little if it's available.
I'm sure we will be able to do that.
Jimmy, you know this is low intermediate, not high risk, right?
Yes, I do.
Great. Delighted to have you here.
I'm on top of things always or sometimes, depending.
I am going to need to talk to you at some point, Jimmy, if you want to send me an address or phone in the private chat on guitar stuff. I have some guitar questions to ask.
Absolutely.
Okay, let's get started with Al. What we'd like you to do is tell us a bit about your story, how old you are, where you are, how you were diagnosed, and what stage you are in the process of going through this. At that point, we'll ask some questions and get some wisdom from the entire group for you.
Okay. I'm 68. Last year, my PSA was only like 3.7. So my doctor wanted me to see a urologist, which then he sent me for an ISO PSA test, which was a little high. And then for an MRI that showed, I think, a 4 centimeter lesion, PIRADS 4. So that was around January of this year. And then I had a biopsy after that. And out of 12 cores, I had one 3+3 and one 3+4 with 15% 4. Sent it, that was at the Cleveland Clinic. So I sent for a second opinion. They said same thing, except they said 40% 4 and seen
Cribriform.
Yeah. Which then later I read back in the notes from the Cleveland Clinic, and they said, regardless of what that says, we don't see any cribriform.
And you said the second opinion was where? I'm sorry.
Hopkins.
Okay.
Johns Hopkins. They called. And they wanted to talk about radiation, or surgery. And I said, well, I won't do either of them. And I said, the only thing I might consider would be a focal therapy. And they said, well, we'll have to run that by the tumor board, whatever that was. So by the time I went and seen the doctor, he came in and they said, yeah, the tumor board said you'd be a good candidate for focal therapy, HiFu, which they do or whatever. And just went over everything. I pretty much, by that time, did so much homework that, there wasn't much he could tell me. And you know, at the end, I said that was like March or something. And I said, you know what? I go, maybe I'll decide something by the end of the year, maybe do something next year. I said, I don't know. I said, I'm not rushing into nothing. And he said, you know, it's a low risk cancer or whatever. So, you know, no problem. Take your time.
Have you done the Decipher test or one of those kinds of analysis?
No. And at that point, the last one before the biopsy, my PSA was 4. Then after the biopsy, the next test was 3.1. And then I had one a few weeks ago, was 3.4. My prostate 61 cc's, so it's pretty big. So I don't believe that that's very high PSA for that size prostate, from what I'm learning.
No, it is not. It's not high. The Decipher would be helpful in helping to determine the aggressiveness of the disease. If in fact Hopkins says there's cribriform pattern there, that in itself is a suggestion that it may be more aggressive disease, although you still have some time. In the Cleveland area, uh, one of the experts in radiation therapy is Dr. Daniel Spratt, and it may be worth speaking to him for another opinion on this, just as far as you go through your research. Um, Other people, other thoughts on this? Anybody else like to comment?
I like the thought of TulsaPro if I had to do anything.
That you said that, Al?
Yeah.
So I will speak to the TulsaPro part as having enjoyed that. I did TulsaPro after being diagnosed with a 4+3. I had multiple readings that were normal on the MRIs and went ahead and did the Tulsa. I ended up a whole gland Tulsa. The gland shrunk nicely. The worst thing I've ever done in my life was the 12 days with the Foley catheter. It led to 2 episodes with bladder infection and chronic epididymitis, where the area outside the testicle developed an infection and have pain intermittently now on and off for the last 4 years. 3 months later, I did a PET scan and found out that the disease actually had left the gland, and I was out $30,000 for treatment that did nothing, and then did definitive treatment. Another thing that you may wish to do or look at is the progress study. And Rick will post the URL for that in our chat group. I'm sure you have that handy. The PROMISE study, it's prostatecancerpromise.org with a few other issues in the URL afterwards. And what they will do is take your history and they will run a free genetic testing looking at 39 different mutations that may impact future risk and or future treatment, and that's free. So that's something that's worth considering along the way. I see that, let's see here, hand up was, Stuart, you have your hand up if you want to go ahead.
Yeah, hi. I did a lot of research on focal, and I was originally pointed at HiFu, and the research in terms of recurrence on HiFu is about as high as any of the focals. I ended up doing focal, but I did IRE instead, because it's got a it's got slightly lower recurrence, and I'm also in a clinical trial that's doing radiation after it. But if you're interested in focal, look at the different options and pay attention to the recurrence rates. HiFu is maybe the easiest tolerated, but it's also got the highest recurrence rate.
Stuart, with the retire study that you're doing, the radiation in effect is treating the whole gland. So I just want to make sure that Al knows what they're doing in that study is going after the bulk of the cancer with the focal treatment, but then following up on the rest of the area with radiation. The concerns I have is that a 4-centimeter tumor is quite large, if in fact that is the size of the lesion. And with 40% involvement with 4, that might push you into an unfavorable category. And I'm wondering, with only 1 core with 4, Rick, what you might say or suggest on that. And I saw you had your hand up, so go ahead.
Yeah, I think I'd be very reluctant, and I think that to embark on focal therapy, Al, and I think that the response you got from Hopkins may have been related to your stating you wouldn't consider surgery or radiation. And
Well,
so,
I didn't talk to anybody there. I just sent them the slides.
okay. So who was it you spoke to about treatment?
Cleveland Clinic.
Okay. Same thing goes at Cleveland Clinic. You know, they're going to respond. The docs tend to take this path of least resistance many times, unless you're with a really good guy. Who is your urologist that you saw at? I don't know them that well. Howard knows the Cleveland Clinic urologist. I don't that well, but who was it you saw there?
I can't even remember his name. You know, I met him twice for 10 minutes.
Okay.
You know, that's what we get these days. They don't know who you are. We don't even know.
Well, no, that's not true. If you follow the way that if you come to us first, you would have gotten more than 10 minutes.
Mm-hmm.
And one of the reasons for that is we tell you to write all your questions down somewhere, no more than 10, maybe 6, 7. Give them that on a piece of paper, and then they'll go through everything with you. And we rarely have people that follow our navigation who feel that they get cut short in their treatments. And I'm pretty sure if you went to see Dan Spratt, you'd have a decent session with him. My concern is, and I don't have the 3+4 guidelines up in front of me, but maybe somebody can pull them up. But my concern is that exactly what Dr. Marks says. You have too much cancer to be considered a grade group 2 anymore, and you would be a grade group 3, even though you're 3+4. So that would make you 4+3, like a 4+3. You're not a 4+3, but other factors push you into the 4+3.
Do you think the nomogram?
Another, or you just take the worst one?
I'm sorry?
How do you believe one over the other, or do you just take the worst?
Just repeat for me again. What was the I'm only interested in the Hopkins. What was the Hopkins score for you?
1 core 3+3, maybe 5%. 1 core 3+4, and they said 40%.
I'd take Hopkins because they have a really good eye. If you ask me, how do you know? We know from lots of experience from the pathologists who are trained there. And that's exactly the reason why, if you hadn't have done that, we would have said to you, send that out for another opinion to Hopkins or Dr. Zhu at Mount Sinai. Now, if you want to get another opinion, to clarify it, send it to Zhu at Mount Sinai. He trained at Hopkins. He'll talk to you. He'll call you up. You can discuss with him and see what he says.
Mhm.
But here's the problem with focal. Plus or minus 50% of men on focal have recurrence. So you're really rolling the dice when you do focal. And you're not necessarily going to avoid the side effects. And when you've got a decent amount, if you've got 40% of a 4 centimeter lesion that's 4, that's 1.6%. That's 1.6 centimeters, 16 millimeters. That's enough. Where was it in your whereabouts was it in the biopsy? Was it at the base? Was it in the apex? Was it against the wall? Where was it?
I'd have to look up the report. I haven't looked at it in months. I don't.
Okay, well, that becomes also very important, because if it's in certain places, it makes it more likely that it can give you grief. And we've just seen too many people who have gone through focal thinking it was the magic bullet, and then they're back again because it's more complicated.
Yeah, well,
Kind of like Dr. Mark, but Dr. Mark didn't get all the way out for a year or 2 years. But don't be thinking. First of all, don't be thinking. I wouldn't be thinking. I certainly wouldn't be thinking. I'm not doing surgery. I'm not doing radiation, because this disease can have pretty adverse consequences. And where you're sitting right now, you're at a place where you can nail it. And the longer you wait, the less likely you are to nail it. So that would be my response. I'll look up the NCCN guidelines right
I know
now.
the cutoff was 20% on 4, but I don't know if that's just in one core or multiple ones. Al, I mean, you've got a couple of red flags here. The size of the lesion, the percent 4, and cribriform pattern. This is not your easy disease that one would consider with focal. There is a study called the PROTECT study that looked at disease confined to the gland and looked at active surveillance, surgery, and radiation. And they found that in that situation, things were about the same, which basically says that if you're a good candidate for focal, then you don't need treatment. On the other hand, if you've got things that take you into a intermediate unfavorable or a grade group 3, by the time you find out that something is going on, it may be too late to shoot for complete eradication. A lot of people will say that if one has 4 or has unfavorable, what you are doing is suppressing disease and controlling it and not curing it. So this is not a touch of cancer in your situation. And while I don't want to scare you, I think from the information you've told us so far, it's something that I would take seriously. Um, Other findings on focal treatment have shown that focal is not going to improve overall survival and lower the death rate from prostate cancer. It is not going to prevent progression, time to progression of disease. What it will do is delay getting definitive treatment, potentially in someone where you had disease that could be managed quite well in one step. I wouldn't ignore this, and I don't think I would go with focal, but I think getting some more opinions and not walking into the docs telling them what you're going to do beforehand, I think it can get you in trouble in this situation. Any other comments from, let's see here.
Yeah, Mark.
How did you hear? I just want to say, how did you hear about us, Al?
On the Inspire site.
Okay, okay. And do we have your email? If you'd like to get reminders for this meeting, you can put it in the chat or send it to us, to one of us individually, Mark or myself, and we'll make sure you get a reminder going forward. That's what we use it for, just to let you know there's a meeting coming up, and it's kind of a newsletter as well. There's stuff in there.
And, George, you had your hand up.
Yeah, I do actually. A couple of quick things. First of all, Al, I think you've done a really good job getting second opinions and doing your research. And let's not lose sight of that because the gentlemen here, I've been on several meetings now, they will express strong opinions, but they're very, very informed. And I can't suggest enough that you should listen to what they're saying. And I think one of the things I've learned from being on these calls is that they really value the centers of excellence diagnoses that you get. And I believe John Hopkins is one of those. As a Canadian, I don't know all this, but that's why I think you're hearing, go back to John Hopkins and or whoever they recommend and dig a little deeper. But I'm impressed, Al, that you've done a lot of work, and you seem to know a lot about this. And to be honest, when I first moved from favorable intermediate to high risk, I was like a deer in the headlights. And these groups really helped me. Also, talking to patients that had the exact treatments that I was looking to. I was deciding between surgery and radiation, or two different types of radiation at the later stages. And I spent a lot of time on the phone with patients that had experienced both of those radiation treatments. And they were really good, and I learned much. I learned the most by just talking to them one-on-one, and what their experience was, and all of that stuff. So I'm sure these guys can hook you up with that, or other groups can. But that's just my 2 cents worth, because I really respect the guys on this call that are leading the call. But I also think let's not lose sight of the fact that Al's done made a lot of effort to sort of figure out where he's at and where he's going.
Well, my brother-in-law had his cut out, and they must not got all of it, so it's back. He's all screwed up. He's got pumps, he's got this, he's got everything. The other friend had his cut out. He tells me if he had to do it all over again, he wouldn't have done it. I had another guy that had radiation, and that didn't do it. It came back, and then he had cryotherapy, and then he's been good for 15 years. My uncle had radiation for a small tumor on his anus, and the day of his last treatment, and they gave him his diploma or whatever, like it was a big deal. He came home, started shitting, and bled out in the hospital overnight, and died the next morning. So what?
Yikes.
I got a bad taste in my mouth from all of it.
Yeah,
I could understand that completely.
That's very difficult, but I would say that in terms of the radiation therapy, Dr. Spratt is world-renowned and experienced, so it's not necessarily going to anybody, but I certainly hear your concerns. Jimmy.
And he's here in Cleveland?
Yes, he is. Daniel Spratt.
Al, I was listening to you carefully, and what you just said, your recounting of some of the people close to you and their experiences, it helped me understand a whole lot better why you said early on that you had been pretty much dead set against surgery or radiation. I mean, considering what you've been close to, it's totally understandable. My only suggestion would be when you meet with, and again, they're so right about, of all of the urologic surgeons there are, of all of the radiation oncologists there are, all the possible treatment you can get, there is unfortunately, or fortunately, if you know, you're very invested in knowing what you should do, small percentage of them are really, really good. So what happened to this person, that person, and somebody else, it's got to be taken into account. You want to do the best thing for yourself. When I say you don't want to let it get away and to gain strength, and then you have to hit it as hard as you can when it could be late. Of course, you don't want that. My only suggestion is that when you meet with these guys, get some more opinions. Definitely, meet with some more doctors. But I would not lead with the firm position that I'm not going to treat with radiation or surgery, because if you do that, there's a chance that they will accommodate that automatically. They don't want to fight you, and they'll say yes. But you may want to keep an open mind enough to listen to what they would have to say, as if they didn't know that you're dead set against it. Because if you're dead set against it, that's fine. But when you tell them that, they're in a position of having to talk you out of that possibly, and they often won't bother to do that, and they may even kind of lose any real investment in caring for you if they think that you're walking away for the only things that they have to offer that they think will be helpful. You know what I mean?
Yeah, and I could never do ADT because I already have osteoporosis. I'm losing my bone density. It's horrible in my spine. It's like how much longer I got anyway, of quality of life.
You probably got a long time, but you want the quality to be as good as possible, and I understand that. That's what we all want. But I think you're in for a very manageable time if you just continue to learn as much as you can and keep an open mind about what's being offered and go to the best people you can. And don't have your mind too made up if you can about what you will or won't do. ADT, I understand. A lot of guys say absolutely not, and I understand that completely. But, sometimes if your disease gets control of you, it can start looking pretty good. But that's nowhere near where you are. So I wish you the best for sure.
Thank you.
Thanks, Jimmy. John S.
Yeah, Al, I'm just going to add my 2 cents. I was petrified of ADT. I had a 4.3, a one-time SK. It's a long story. Dr. Nagar, Decipher score, as Mark mentioned, get that Decipher score. And your crib form is not favorable. And that's what turned it around for me. No ADT right now because the Decipher came in low. And you want to catch this before it bites you in the ass.
Insurance don't pay for that, does it?
Like everybody else says. So right now I'm not looking at any hormone therapy, but I'm struggling with other things. But that's I'm new here. June 26th.
One of the side effects is osteoporosis, and I already have osteoporosis. So I could never take it.
Well, they might put you on some of the agents to support the bone, and that may be helpful whether or not you choose ADT. You mentioned tumor board. When you go to a tumor board, it's not like going to an individual doc. They present the case, they look at all these comorbidities and take all that into account to figure out what might be the best option. One other comment I wanted to make was you had said about the PSA jumping around. PSA is kind of like a check engine light in a car. It doesn't tell you what's going on. And going from 3.1 to 3.7 or bouncing around like that doesn't really play a role here. A lower PSA doesn't necessarily mean at this stage that the cancer is less aggressive or less concerning than it might have been before. I think the biopsy is what is really telling here, and I think the Decipher will add to that. Stuart, you wanted to make a comment.
Yeah, Al, are you on regular Medicare?
Yeah. Well, a supplement.
Well, okay, if you're on regular as opposed to Advantage. If you're on regular Medicare with supplemental, Decipher is covered. I know that because I had one done. And the other thing is, if you really are interested in focal, talk to some of the really top focal guys, because everybody and their uncle does HiFu because they happen to have the machine. You want to talk to some of the really top guys. They're really accessible, and they'll give you their straight opinion as to whether you're a good candidate or not.
Mm-hmm. Okay.
Okay, Rick.
I just want to address the osteoporotic comments, Al. I was 56 when I got diagnosed, and the treatment path I chose included 28 months of hormone therapy because it was very likely I would need it even if I did surgery. And when they did a bone density test at 56, it came back that I was osteoporotic in my spine, which you could have knocked me over with a feather, except that when I thought about my family, it made sense to me. And I did the 28 months. I got bone strengthening agents, which are usually reserved for more advanced cancer during that time, 3 transfusions of zoledronic acid or Zometa. And I also changed my exercise schedule. And I tried to do exercise that stressed my spine.
I do all that. I got an osteoporosis doctor, but I don't do none of the drugs.
And when I started, my spine, the density in my spine was minus 2.5, and when I finished, it was 0.9.
Mine is 3.8.
Michael.
Yes, I really respect what Al had gone through and the research he done, and also the comment about everybody else. But I listened carefully with Al's story, and I believe that I want to add 2 cents on that. That seemed to me that some of the radiation treatment that your relative or friends had some time ago, technology had changed quite a bit, and I'm just wondering whether you take that into account for radiation therapy, because current technology seemed to be quite a bit advanced compared to something 5 years ago, even 5-6 years ago.
I've been on so many support groups and stuff like that, that I hear so many stories about everything. So that probably don't help either. As far as the bone meds for osteoporosis, I ran into 2 guys that they're getting necrosis of the jaw and their teeth are falling out from the osteoporosis medication, which is a side effect of the osteoporosis medication. I mean, it just goes on and on.
One thing that you might consider doing if you meet with these docs, with 40% and the large tumor size, they would put you into an unfavorable group. They might be able to push for the PET scan. And with a 4-centimeter lesion and cribriform, I think I'd want to get that PET scan before
this conference
then
will now be
continuing with
recorded.
active surveillance. If all those other things are ruled out.
I realize I'm in denial too,
I'm sorry?
I realize I'm in denial too, I mean.
It's a difficult situation. And I'll tell you that probably for most of us here, this process of figuring out what we do, is this real disease that potentially has a risk of causing us problems, or like we hear so often, this is a disease that you get. It may not be a real disease. You'll probably die from something else with having this. That's stressful. I mean, we're used to most of us are used to being healthy, and being faced with it. The worst part of the whole process, I think, is the decision-making process and conflicting information and hearing from friends and buddies and the like. Okay, let's move on here. Next is Enrico. You kind of see a bit about how we are operate here. So if you could tell us and share your story, that would be great. We'll see what info we can provide.
Great. Thanks for having me on here. I'm 55 years old, about to turn 56. In January of this year, my PSA jumped above 4, went to about 5.7, and then doctor said to retake it 3 months later. So in March I took it and it was around 4.7. They said they recommended doing an MRI. I did the MRI and it came back showing a right postal lateral midland peripheral zone, 1.5 by 0.5 centimeter, and a PRAD score of 5. So then they recommended doing a MRI, a biopsy, MRI guided biopsy. 10 core samples came out, 6 were negative, 2 had a 3+4, and then 2 had a 4+3 with a 75% pattern. Based off that, the surgeon, this was all at Mount Sinai. I'm based here in New York City. I'd recommended that I get surgery. I met with Dr. Tawari, and basically they scheduled surgery for full prostate removal on end of November. I was basically a nervous wreck. I really don't want to be doing the surgery. And so, and I felt like this thing was just kind of going a little quickly, considering that I basically got diagnosed with cancer not even 3 weeks ago. And so I decided to cancel the surgery and start just understanding a little bit more what my options were. My baseline urologist basically said, this is slow moving cancer. I'm catching it early. The digital scan showed that it had not left the prostate, and it was, I think it was a T1C is what they're saying, but I haven't confirmed that. And I just spoke to a friend of mine that is one of the head radiologists out in Oklahoma, just to kind of get his opinion. And his view is that basically within the last 5 to 6 years, the radiation therapy has gotten so good that in his opinion, kind of 50 and over, he would say he'd lean more towards doing radiation or not. So right now I am meeting with Dr. Robert Stewart at Mount Sinai tomorrow, who's a radiation urologist. And then I'm meeting with I think his name is Dr. Murillo, who's kind of a urology oncologist at Mount Sinai next week. And then next month, I'm meeting with Dr. Nadir, who is kind of the head of the radiology at Sloan Kettering, to kind of get a feel and get their opinion on kind of what's the best approach. Every surgeon I talk to basically says, go surgery, and they think that's the best route. I'm honestly petrified, absolutely petrified of the surgery. I've talked to a few people that have had it, and it just sounds absolutely awful. And it's the radiation seems like kind of a better alternative. And the good news is, I guess, from what the urologists have all told me, that I have, I don't have to rush this. I have a few months. I shouldn't wait a year, but I have a few months to kind of figure out what my best course of action is, and that's kind of what I'm trying to do. And so a friend of mine, Mike Harris, had mentioned Rick in the support group here, and so I'm right now just trying to get as much information as I can, because as someone on here mentioned, it's like this decision-making process is petrifying. I'm scared out of my mind, and I'm scared of the side effects specifically. Particularly ED and incontinence. Like I just both of those things petrify me to have that for the next 30, 40 years, even if I get to live a nice long life. And so I'm just kind of trying to figure out what to do. And then, I think you guys mentioned focal. Is that the same thing as IRE? Or is that something different? I don't know. But that's kind of where I'm at. I'm meeting with a bunch of different doctors. Fortunately, being in New York City, I get access to a lot of, I think, good quality healthcare. But I'm basically trying to figure out, what are the options out there. And another thing I heard was that because mine is located just on, one specific area, that there could be a possibility to do a partial removal. I'm not really sure what that entails. I'm supposed to meet with some kind of surgeon on that too, but that's where I'm at. Ball of nerves and trying to soak up as much information and trying to make the right decision going forward.
I think that you're talking to good people, and you will get the information, and you should be able to make a decision. Again, this is the worst part of the process. If you do the homework and get that information first. I'm particularly enamored of Dr. Nagar in terms of hearing him speak and having been on panels with him. I think that he is top notch, both in terms of research and understanding state of the art equipment and radiation therapy for this. Looking at the studies overall, I think it's not clear that whether you do surgery or radiation, one is going to give you a better outcome than another. You can't take your data and plug it into a nomogram that is at MSK, and that nomogram will allow you to determine, if you do surgery, what % of the time there will be node involvement. And I'm sure that's something that they would run, Dr. Nagar would run, and use that to advise you in terms of would radiation be aimed just at the prostate gland or at the prostate and the lymph nodes. My thinking about this, I must admit I'm biased. I am a retired surgeon, and I did minimally invasive surgery, and I wouldn't go anywhere near an operating room unless there was some reason that radiation was toxic. And if you're already catheterizing yourself because of BPH symptoms, then the surgery might be relevant. But for most people with today's advanced equipment, you're going to find that, yes, you still can have problems, but the risk of incontinence is nil. The risk of GI side effects is nil. Some docs are recommending putting a gel between the rectum and the prostate to lower radiation and side effects to the rectum. I'm finding that a lot of people are not recommending that now because they just don't feel that with the MRI guidance and gating, which turns off the beam if there's any movement, that the risk is the same as in the old days that we heard about. Did you say you had a PET scan that showed that the disease was confined to the gland?
Correct.
Okay. The other thing in the chat window.
What type of PET scan was that, Enrico?
Well, so I had 2 scans. One was just a digital scan where they stick a very large looking dildo up your anus, and then the other one was I just did it was the nuclear PET scan where they inject nuclear whatever, and you wait an hour, and then it was a full body scan from head all the way down to my knees, and that one basically showed nothing, no inflammation, no nothing except for the prostate and the right peripheral area, which basically showed, confirmed that, what the MRI had shown. But that was it. There was nothing else.
That was not a PSMA scan, it sounds like. That full body scan.
It was it's called a PET nuclear scan, with whatever that is. They inject the nuclear dye inside of you. You're radioactive for like
an hour.
I'm sorry?
Polarify would be an hour, Rick.
Yeah, but I'm guessing. Yeah.
I think what we're saying is that there are a lot of different agents that are radioactive. In the olden days, they did technetium-99 as the radioactive agent, and that really wasn't specific. Now they have either gallium or a fluoride radioactive molecule that attaches and binds to the PSMA on the prostate or prostate lesion, so that it's far more specific. So it's important to know, did they use Pylarify or something called Posluma?
This is what this says: intravenous contrast, 8 millimeters of Gadavist. It's a Gadabut roll, something like that. 1 millimeter solution is administered intravenously. So Gadavist, Gadavist, and it was basically MR prostate with without IV contest.
That's the Gadavist isn't that gadolinium?
It says Gadobutrol is what it's saying. 8 millimeters of Gadobutrol, which is Gadavist.
Yeah.
It sounds like an MRI.
It does sound more like an MRI dye than a PET scan. Did the machine make a lot of noise?
A little bit. It was like, circular machine, you're inside, and it just goes, no, it didn't make a lot of noise. No, it was like just, that kind of noise.
Well, it's important to ask and make sure what dye they used. You could come back and ask us again, and I'm sure that the docs at MSK or Mount Sinai would want to know exactly which it is, because that's important. If it was technetium or just a dye used on the MRI, the MRI doesn't tell you that the disease is confined to the prostate. So you want to make sure that you actually had a PET scan. The other thing in the chat window, Rick posted the PROMISE study, and the PROMISE study looks for the prevalence of genes that may make one more prone to have this cancer, and then offer clues later on to increase treatment options that might be available in the future. So that's something I would look at. It's a test that's free. They send you a kit and you do a cheek swab.
And this is the Decipher prostate one? Is that
No,
what it's called?
Decipher is with 4.3 and 75% 4 in it. I think the Decipher is not where you want to be. I would think that you would not be a candidate for focal. And the Retire study that had been mentioned requires 3.4. So I think at this point, for someone who wants to avoid surgery, modern radiation therapy might be the most appropriate option. Mike, you had your hand raised.
Yes, I'd like to kind of add something for Enrico. If you look online, they just put up the video for the September 2024 from the organization called PCRI.org. And essentially, if you look at the third participant, or third presenter, Dr. Mark Roche from UCSF, he seemed to be a very seasoned radiation oncologist. Your question regarding surgery versus radiations and different types of radiations and what the side effect, he answered it pretty succinctly in that session, and this particular session. Take a look at them, to answer some of your questions that, essentially he talked about that if you have surgery, your side effect is immediate. And if you have radiation, it's going to take a bit longer, but then he shows some data about side effects and the pro and cons and different types of radiations, radiation treatment. So it's worthwhile for you to look at it. It's a very long, I watched it technically 8 hours total for the entire 2 days session. But the third person is Dr. Mark Roche from UCSF. It's very helpful.
Okay, we'll take a look. Thank you.
Anybody else have any comments for Enrico? Okay, well, after you've spoken to these additional people, it'd be great to come back and hear what your thinking is and how you put all that in the filing cabinet and decide which person you want to listen to. I think part of it is the feeling respected, feeling heard, and then having to put your faith in someone that you're willing to go with their judgment. There is no way that any of us can expect to understand the full body of knowledge that goes into planning and carrying out these treatments. This is not something that any of the people we've talked about are going to wake up and spend a few hours and become experts in it. They've spent years working in the field. I mean, someone like Mac Roach or Nagar or Keyshawn or Daniel Spratt um, just have far more experience than the average person who may be out there and selling themselves as an expert in treating this. So you do want to find top-notch people and getting the opinions, and I think you're well on your way to doing that.
I do want to jump in. I didn't get in time. Enrico, have you resolved sending off getting Dr. Zhu to look at your slides, or did you find out if he did?
I got the form today, and I talked to him today, and I'm sending it all up tomorrow. So within the next, hopefully, week, I should have that. So yes, I'm definitely getting a second opinion on the actual lab results.
Yeah. So that's something that I think is really important. Secondly, I just wanted to talk a little bit about this anxiety because it's paralyzing. It can be paralyzing, and we get it. I'd like to recommend our Men Speaking Freely group because there's some really good people in there who can help you, including some professionals who are there as peers. And the next meeting for that group is the 3rd of, the next meeting for that group is going to be the 7th of November. And we're pretty good at suggesting some techniques. I mean, most of us, I was diagnosed at pretty much the same age as you, and it's a big weight when you're trying to make the right decision. And in your case, I think one thing that we know you're going to have to do, I missed it. Did you say you were 4+3 in that? Yeah.
Yeah.
You're going to have to do some treatment. So
right. So the option of doing nothing, sticking my head in the sand is not. I don't think that's
exactly
a very viable option. No. So
exactly.
I have to do something. Yes.
So what we got to do is make that treatment path the easiest for you. And when you're ready to, when you feel like you're going to shriek, you reach out to us. We'll help you any way you can. But I think that as you get your arms around more knowledge, you've got some really good people. Nagar's very, very good. Zhu is excellent on that level. Did you fill out the nomogram?
I haven't yet. I will.
Okay, so you fill out the nomogram because in my own case, the nomogram told me that surgery alone was going to give me only a 30% chance of not needing more treatment. So, I mean, it was pretty much a no-brainer that I wasn't going to do the surgery because there wasn't enough extra out of it. We've got guys in this group who have done surgery. They'd be happy to talk to you. We've got guys in this group who have done radiation. So keep coming back to the group, keep asking the guys, what about this? What about that? And make sure that you ask your doc the right questions. And if you're not sure what to ask, we can guide you on that.
Great. I really appreciate it.
So I would add to the question list, am I a candidate for SBRT? Would be a good one. And then what is the role that ADT plays? There is an Artera AI that allows you to plug all the information in and will quantify potentially any benefit from adding ADT. So you can determine and make an informed decision rather than, going in and saying, I don't want it. None of us want it. None of us want it.
ABT is the hormone therapy?
Yes.
Yeah.
Yep.
Yeah. So the radiologist I spoke with, just my friend, said that, for 4.3, the standard treatment, you're probably going to get 8 to 10 radiologists say that you would do the radiation plus the ABT. He said in his opinion for 4+3, the ABT only added 3 to 4% as far as success and not having reoccurring. But it added a lot of like quality of life things that you had to deal with for the next 6 months to a year. So in his opinion, like given my condition that it wasn't too serious yet, that he actually said that in general he'd be okay treating without the ABT, and then kind of seeing how it goes. But that's just his opinion. I'm certainly,
Yeah.
Dr. Nagar and all the people, I will get everyone's opinion and see what they say. I'll be
You
open
do
to
want-
anything.
Is he a special? Does he specialize in prostate cancer?
Yeah.
He does.
Yeah.
Okay.
Well, I do think the nomogram is a tool now. The Arteria AI is a tool that quantitates it. From what I understand in my reading of this, a 3% improvement or benefit would be low. Certainly for someone with 75% in the cores, I'd have to wonder about that, and that's why I'd want to hear from one of these people at a center of excellence.
And that's why I'm not taking that as gospel. He just threw that out there, so I throw that out there.
So
out of curiosity, how bad is ABT? Like, is it just brutal?
So I had double. I had the injection with Lupron. Now we have Orgovix pills, which are easier to deal with. And then on top of that, because I had disease outside of the gland, I had abiraterone. Testosterone was totally undetectable, and I had that for 6 months. And we do exercise, strength training, and aerobic to maintain the strength. I told my wife no carrying packages up and down stairs, and I wouldn't do ladders. And I did feel a bit frail while doing that. I only had hot flashes twice. I was one of the lucky ones who got through this and then got off after the 6 months. And I've been undetectable on PSA now for close to 4 years. Actually, I'm a little bit more than 4 years, and I'm back on testosterone replacement therapy. And this is the only involvement I have or different from before prostate cancer is coming to these sessions. So you can put prostate cancer behind you, and a lot of people will in a situation.
Mark, can I just answer the ADT question? Because I usually run the advanced group. There are a couple of guys in there who have experience, but I did 28 months. Over 6 months, which is what 6 to 8 months would be what they would prescribe you. If you do it, I don't think you're even going to notice it. Especially if you go with the recommendations that we would give you. So I personally would not be intimidated. We work with a lot of guys, hundreds of guys that have done ADT. Some guys have some response in the first few months, but it's not that severe. And my own personal opinion is it's worth its weight to go through with it. But everybody has different opinions, and you'll see what somebody like Sprad or Nagar has. Al, you have your hand up.
Well, I just want the doctor that for the third opinion, Dr. Zhu, is it?
Zhou, Zhou, Dr. Zhou.
Okay.
He's at Mount Sinai. He trained at Johns Hopkins. He then went to Tufts, and he recently moved to Mount Sinai. Enrico, how did you get that form? Because I know it was a little difficult for you. How did you eventually get that form? Share with Al.
I called my urologist who did the biopsy, his assistant, and I said, "Hey, I want to get a second opinion. I need the form. Can you?" And she sent me. She's like, "Oh, you have to contact the lab, but I'll have the lab send you the email that you need to fill out. I mean, we'll send you the email that the lab needs filled out." And so I have now the form for the lab. Came from the doctor that did the MRI. I mean, sorry, the biopsy. I keep saying MRI. The doctor that did the biopsy. their assistants will send you a form.
Okay.
That,
But
that
you were at Mount Sinai, right?
I was at Mount Sinai.
Yeah, so that's not going to work for Al. Al, I'll give you an email. I'll put an email address in the chat window for you. The other thing is you can just ask your urologist, and most of them know what to do, that you want a second opinion from Dr. Zhu at Mount Sinai, and tell him you're an AnCaner because he knows us, and he's pretty good guy, and he'll call you up afterwards and go through it with you.
In your experience, is there a lot of difference between biopsy results, or are they all pretty much the same?
Look, the thing with the biopsies, at least today, because with AI, we don't know where we'll be in 5 years from now, but it's the impression of the eye. And some of the docs have very, very good eyes and therefore see different. I finished up getting 3 different opinions on mine. The best in the game was a guy called Jonathan Epstein, who right now is out the biz, but might be back in soon. And he trained most everybody at Johns Hopkins, including Dr. Zhu. And Dr. Zhu then left and went to Tufts, and he recently switched and went down to head the lab at Mount Sinai. And of course, they all have expertise in different cancers, but Zhu and Epstein are really strong. There was a guy called Boswick who's been in and out of the business. He read mine years ago, but he's since then there's been some issues around him. But Zhu is really very good, and he likes us, and he'll give you the time, and I would rely on his opinion.
And I made a mistake. My lesion was only 1.4 centimeters.
Okay. Okay.
It's a little, that is better. Yeah. Rick, I wanted to ask you a question.
Yes.
Are you sure on the pronouncing of Dr. Zhu's name? Because my understanding from my 2 or 3 Chinese lessons, that Chou would be Joe.
Well, we've called him Zhu, but it might be Joe, and you're free to call him Joe if you would like to call him Joe. What I can tell you is Howard Walensky, who's well known in this biz, mostly for active surveillance, and he has a website called The Active Surveiller, has interviewed Dr. Zhu several times. So go to his website, The Active Surveiller, and you can find out about him. He's done, Dr. Joe did a webinar for us. So if you put ZHOU in our search window, you'll find the webinar he did for us. And that's it. Okay?
Okay, great. Let's move on here. Mike Nguyen, you had said you needed a bit of time.
I just yield the floor to anybody who got more of a prostate cancer related, because my more comment toward the so-called what Dr. What's his name, Mac wrote, referred to the so-called gating issue with Villeray and so on and so forth. So somebody may have more urgent questions to ask. So let me yield the floor to them.
Okay, great. Greg, you're up.
Good evening. A couple of comments about Enrico and Al's situation, and I'll then get into my question. Number one is that do yourself a favor and get as much diagnostics performed as allowable for your case. Because as you talk with the second and tertiary opinions, this will give them a better picture of your specific situation, and try to eliminate as much gray matter as possible, because they truly operate with objectivity based on the situation. And then number two is Dan Spratt, who was formerly at University of Michigan, and then and he hired my rad onc that I'm my attending over there. But I've spoken with him personally, and he gave me a great sense of comfort for a second opinion, and he's now at University Hospitals of Case Western. The other part is that yes, not only diagnostics have improved over the last 5 years, techniques and the tools available, but the best tools available in the wrong hands are just as bad as the old tools available in the bad hands. So you want to try and get good hands with good tools to treat your situation when all is said and done.
Great. Thank you, Greg. Do you have a question for the group?
Yes. Okay. Question for my situation is coming up on 12-month anniversary of radiation treatment, and I was just wondering about laggard side effects with that, because I attended a recent webinar put on by Zero where they spoke about the fact that the radiation penetrates good tissue as well as the bad, and in spite of the fact that it is definitely higher quality today than ever before, there's still some small effects that could be taken up by good tissue. And I was just wondering, in relation to specifically arthritis, hip in the pelvis or the hip area, has anybody experienced or do you have any knowledge of that?
Those areas are specifically protected, and when the treatment maps are designed, they're set up to avoid the hip area specifically. Again, it depends upon the machine. If you're looking at an MRI Linac, you're looking at 15 beams. If you're looking at proton, you're looking at just 2 beams. So all the energy is coming through 2 pathways. You have the Bragg effect that gets talked about. If you look at CyberKnife S7, that moves in a complete sphere. So the radiation is coming in through many different paths, and protecting any specific area will be far easier with S7 than it might be with a TrueBeam or an older setup. There's also the fact that over the course of treatment, if you're doing 28 days of treatment, the gland can swell. Someone has a lot of background noise. Let me see here.
Mine was only 5 sessions. So.
Oh, okay, yeah, you had SBRT. So again, there it depends on the margin. Some of the machines are using 5mm margins, and some are using 3mm margins. So you're reducing up to 60% in the volume of normal tissue that's radiated. But again, specifically, the treatment maps avoid areas like the hip. So I don't think that would be an issue. Okay. Let's move on to John.
Correlation is not causation, so thanks.
John?
Yeah, hi, Mark. I just, September 9th, you guys started talking about the space gels, and that kind of set me off with not needing it. And I don't know, I've been banging my head up against the wall. I went to see Nagar last week, and I asked him straight out, third meeting with him, he goes, no, you don't need it. But there's still something in my head tells me the 25% reduction could prevent maybe some prostatitis. What is it called? Prostatitis? I don't know. I don't know. I looked at Dr. Roach's. He's against it. he doesn't use rectal spaces. And interesting, we had a conversation yesterday with the MRI guided and his take on that. That's another discussion with. But yeah, right now I'm just stuck on rectal spaces. I mean, he could do the Barrigel or the balloon now they do. But do I really need it? Rick told me I didn't. Just
I
kidding.
think
Rick.
it gets to a point where you have paralysis by analysis.
Yeah.
You are talking to the top people, and top people are telling you you don't need it. Now,
Yep.
short of spending 5 years studying radiation therapy and experiencing patients, you're going to drive yourself nuts, second guessing
Yep.
all the docs. Know that you're seeing the right people, and you've got to trust them at some point. There's
Yes.
nothing. I mean, even if you do the gels, you can have issues.
Yes.
But I think making a decision and learning how to trust is going to be important. That may be something that you'd want to come to the Men Speaking Freely group and just talk about this. How do you trust your doctors? Not going into the specifics of your issues about what you're trusting them about, but trust is really important. When I was a doc, I was doing infertility, and there were some people who would obsess about every detail. And what I found is that those who were able to move away from their obsession, which is not to say give up and not educate themselves, but those who were willing to, I guess, surrender to the process and accept that they are doing the right research and they're with the right team, really had the best outcomes. And I think
Yeah. I
that
mean.
I want to consider.
Yeah, I mean, I just got to make a decision and to go back now, and I mean, I went to see him. He was perfectly no hesitation. He says, "No, you don't need it." I mean, I guess I'm just gonna have to. What's the chance of getting something less than 1%? Even a study.
There was a guy who went into the clinic, had radiation, and he did his 5th treatment. He walked out, he got hit by a bus and was laid flat afterwards.
Yeah.
Unless you're going to stop all traffic when you go to the clinic, you just
Yep.
don't have the ability to control
I
every
know.
aspect of prostate cancer and what
See,
goes on.
Enrique, even I'm well along with this group. I know the doctor I want to get treatment with. I'm still paralyzed. So with every aspect of it.
I feel you, man. I feel you.
I'm a little older than you, 68, but it doesn't matter. I'm very active in all aspects of my life. So just a quick note, I had AFib for 10 years. I've been battling it, but I found the doctor, Andre Natali. I met him at in the city. He came to St. Luke's to set up EP labs. Sat down with him for 3 hours, an hour, consulted with him. I knew he was the best in the world, and he took me right on the spot. You want to go now? Did you eat? And I put my trust in him, and I just went back to him to follow up, and I went up to get the Watchman procedure. Anyway, but
John, we got a lot of people here
Yeah, go
who
ahead. I'm
want to
sorry. That's
contribute
it. That's all I
tonight.
got to say.
Does anybody else have any experience with paralysis by analysis and how they broke that so they felt comfortable with the decisions they made? What was the thing that finally made you accept the decision that you made about treatment? Richard, you're up next anyway, but I'll let you go ahead here.
The best thing I did was to join the AnCan groups. They helped me all along. Yeah, just a couple sessions with this, and your comfort level will come back, is the way I would see it for you. Yeah, because it's the collective wisdom of everyone here, their experiences, that just it'll guide you in the right direction. So am I ready for the next?
You had your hand up.
Okay.
We'll come back to you, Richard, in a second, then to get your question. Boykin.
So I think one of the keys is you have to find the facts. And once you find the facts, and then you have to decide what it is that is most important to you, because no matter what, all of these treatment options, don't care what they are, they all have side effects. So you, my friend, have to choose your poison, and then move on and be happy with it. And you can have peace of mind if you feel like you've done the right research. But the more people you ask, the more opinions you get.
Okay, great. Richard, you had a question for us tonight.
Yes, I'm gonna thank you. I'm gonna give you a quick recap, and then which will lead to my concern. I had all of my markers were high. You know, PSA 11.7 and Gleason score was a 7, 3.4, et cetera, et cetera. And so I started SBRT at the end of May. My PSA was 11.7 and went into the SBRT treatment. And unfortunately, concurrently with COVID. That was fun. Anyway, so came out of that, had a little bit of discomfort with urination initially. Then I got a prescription, and that was fine. Now, about a month ago, some side effects have occurred. The discomfort has returned. The nighttime frequency is now up to 4 per night. Sessions per night. The urgency has certainly increased, and with some leakage. So that was my only level of anxiety for a while. But my first follow-up appointment with the oncologist, actually it's coming up Wednesday, this week. So I had a PSA test last week, and that's what my concern is now. Through all these sessions, I've heard everyone that's gone through SBRT report back having PSAs of less than 1.0. Well, mine came back to reading as 5.97. So I'm not sure what when I'm facing here for the next several months or so. I mean, is it going to be like another period of active surveillance, or is this spike normal? It is a drop from the 11.7 prior to radiation, but it's still pretty high in my opinion compared to everything I've heard from people in these groups. Any thoughts on this PSA of 5.97 and what next steps will be?
Had they done a PSMA PET before you got treatment?
No.
So then I think that would be something that would certainly be in order. I'm concerned because I would expect that they would have done that before treatment to understand whether to cover lymph nodes and whether there are any involvement there. So that would be the first thing, is to push for the PSMA PET. It may very well be that the Posluma PET is optimal because the dye is not excreted through the bladder, so they get a clear picture of the base of the prostate. I don't think it necessarily matters for pelvic lymph nodes with it. That level, we'd like to see it lower at this point, but as long as it continues to drop, it would be okay. But I'd be concerned without having had the PET scan before. Anybody else have any comments? Paul.
Yeah, so to follow up on Richard's question, I've read that it will go compared to surgery. If you use radiation, it'll ramp down, not as fast, obviously. So, what is the actual nadir value for radiation? Does anybody know? What do you say is the nadir, is the goal you want to get to? Does anybody know what that nadir is for
Richard,
radiation?
what was the lowest? Oh, Paul, you're dropping in and out. We can't hear you.
Oh, I'm sorry. So my question is, does anybody know what the nadir value for radiation treatment?
What was your lowest PSA, Richard? Was this the first PSA after treatment?
Yes, it was. It was just last week, and my first appointment since radiation is going to be this Wednesday with Dr. Stephen Greco. But that's the first PSA reading since treatment.
Paul, I didn't understand your question. Are you asking Richard what his nadir value is, or are you asking something in general about nadir values?
I'm asking in general. In general, that's the question. What is it?
You're asking in general about nadir values with radiation?
Yes.
Okay. I'll pass that one off to Dr. Mark. I mean, all I can tell you is that every person is different. And some nadirs are very, very different to other nadirs. It also depends on the type of radiation. It depends if you're on hormone therapy, because that can mess things up. It depends on a bump, because that can mess things up. There's no easy answer to your question. Dr. Mark?
So absolutely, without the doing ADT, I don't think I'd be alarmed. I'm more alarmed that they didn't do it before they treated you, in the beginning. And they might have a hard time putting this off as progression to justify the PET scan. But I think with the 4+3, doing a PET scan beforehand would have been relevant. The thing with radiation is that you radiate cells and they don't necessarily die. They're sitting there radiated with damaged DNA, and you don't really find out that those cells have been damaged and killed until they go to divide. So it's only at that point that the cells die off and that they're going to stop making PSA. If they're sitting there and you radiate the whole prostate and the cells haven't divided, you're not going to see any drop at all. It's not unusual in your situation for it to take 2 years or potentially even longer.
Oh, really?
And you can do the PSA and you want to see it trend down, and occasionally it can bump back up again, because all of a sudden the cells can say, it's springtime, we're going to start growing again, and they start to grow and they die, a bunch die off. So it can bounce around. What you'd want to do in that case, if you see a jump, is repeat it and make sure that it's not trending upward again if you do see a rise. But I don't think that number in itself is cause to be alarmed.
Okay, well that's at least that's good to hear. Okay.
Anybody else have comments on that?
No, but Dr. Mark and Rick, just one quick thing. Sorry to interrupt here, but I gave you the wrong information when I was telling you about the PET scan. So the agent, I'm just curious your opinion. The agent that they used was up 9.5 MCI F18 DCF PYL is what they put in.
Okay, so that's Pylarify, and that's great.
Yeah.
That's a good one.
And so if it's saying no evidence of regional nodal or distant metastasis from the prostate,
Well,
then
let's talk about that. There's two different things here. What we hear when we get that report back is, I don't have cancer outside the gland. That's not what the report says. In the small print, what it's saying is, we don't see any evidence of disease outside the gland, which is why people can still have recurrences after radiation, and it balances that. Whether it's MRI or PET scan, none of these are, completely accurate. And depending upon the size of the lesion and the degree of the disease and how it's treated, the sensitivity of these scans can vary quite a bit. So you want to say, yes, I'd much rather have a PET scan that didn't show anything, but it doesn't mean that I'm cured if you do a PET scan and you don't see it. It means that you don't see it.
fair.
Rick.
Yeah, I mean, the reason that I did so much treatment was because they felt fairly certain that there could be micrometastasis. Now there wasn't a PSMA scan in those days, and I had disease that was outside the gland that they could see in the prostate bed, but it's the old micrometastasis ghost that haunts a lot of us. And if you've got a really good medical team, they're going to give you the best advice as to whether they think you should add or you shouldn't add, and get second opinions on that too. With if micrometastasis is a possibility.
Okay, thank you.
Okay, Jimmy, you're up.
I'm up. Hello. Good to be here. Good to hear from everyone. I've never attended this group before, but I've been an AnCan member since 2020. So basically, I'm a little bit of a man without a country, and the shortest possible explanation is I had surgery in 2019. After the surgery, the pathology report showed adverse. There was no PET scan available that I would have been able to know, but the surgeon advised I go to medical oncologist. All this was at Hopkins. My brother was a doctor in Annapolis for 40 years, so he sent me up there quick, which was nice in retrospect, before I knew anything about centers of excellence really mattering. Anyway, the oncologist said, if you do no further treatment, you will be dead from metastatic prostate cancer in 10 years. And I said, well, what else you got? Of course. And he said, if you take the standard of care additional treatment, which is MRT radiation and 2 years of hormone therapy, you have a 50% chance in 10 years of being cured, and the other 50% chance you'll be alive, but you'll be fighting it. If you take this clinical trial I'm offering, you have a greater than 50% chance, but we have no idea how much. And the addition was abiraterone and chemo. And so I nicknamed it the kitchen sink trial.
Wow.
Although that wasn't its official name. And off I went. And I joined AnCan during the pandemic. And as I went along, got to know everybody and really, really enjoyed it, and really, really went through a lot of jubilation and seeing people have a really hard time. Guys died. It was truly a support group of the first order. And I tried a couple of others, so I really liked it. Still like it. But it's now been, the treatment was completed in 2020. ADT effects wore off completely. That is, testosterone returned completely by April of 2021, and I've been undetectable throughout. I was undetectable after surgery. So the additional treatment wasn't based on raising PSA or anything after surgery. It was based upon the medical opinion of my team. So after all this, I'm over 3.5 years now undetectable after full return of testosterone. And in the advanced recurrent group, which I'm a card carrying member of, to my knowledge, I'm the only one in that group that has this kind of situation. Most of these guys are metastatic, and they're on ADT and so forth, and I am not. And so I come here because this is the only other group really to come to in AnCan, and I really don't know where I belong, if I belong anywhere. I love being a part of it. I could still be a part of the advanced recurrent group, but every 3 months when it comes around, I say, well, I'm doing fine. My testosterone's 700 something. I'm sorry you guys are having a hard time, but it's pretty good over here. I don't say that shit, of course, but it's like, I'm in a tough spot a little bit, and that's all. And I must say, surgery, if I had to do it again, I would never get surgery. I have run into more guys that have recurrences from surgery, and the nerve sparing, erectile function sparing surgery, I can't help to think it's oversold. And that if you want to avoid erectile dysfunction, you probably want to avoid surgery. That's only my own, not even opinion, but just my guess. And it certainly was my case.
Jimmy, I'll second that opinion. I certainly agree with that. What was your Gleason score?
It was 4+3, but I had 80 to 100% saturation in the cores. With half the cores in the prostate were positive. Some of them were 3-4, more of them were 4-3. It was about 80% pattern 4 and 80% saturation in the cores. And I had seminal vesicle invasion and one positive lymph node in my pathology. So definitely serious disease. And I'll never know if I so-called overtreated, but I never think about that. I have met enough guys who've been dying from this disease and have had a very, very hard time. And I certainly, to where I sit, despite the consequences of treatment, which are real, I still feel like I made the right decision overall. Wish I'd had a PET scan back then, but no, that's it.
Well, you had with a lesion positive, I'm not sure what that would have changed. They might have radiated the pelvic sidewalls and lymph node chain, I guess, had they known that there was additional disease. There was an interesting study a while back that this group of surgeons had high-risk patients and did the PET scan beforehand and identified lymph nodes on the PET scan before going into surgery. Post-op PET scan showed 30% still had positive nodes after a thorough lymph node dissection where they knew they were going to find disease. So I don't know that you necessarily are more likely to cure disease by doing extended surgery.
I wish, let me be clear, I wish I hadn't done surgery at all.
Right. You did and the other thing now, they're recommending the docetaxel for people with high volume disease, which I don't think you would be considered. So in a way, you may have had invisible high volume disease since we couldn't detect it. And we're lucky to get that. How did you do on the docetaxel?
The docetaxel wasn't too bad. I didn't have that bad experience with side effects overall. I thought I'd just very quickly add that if you take the exercise seriously, you're going to have a better time with every single one of the side effects, I guarantee it. And there was no exception with the docetaxel. Plus, I only had 4 rounds instead of 6, and that was pretty much over before I knew it. Also, the ADT, for anybody who's only doing 6 months, I didn't feel a thing until 9 months to a year. And so I think that is, as Rick said, fairly typical.
That was my experience as well. Bob S., you had your hand up.
Hi, Jimmy. Jimmy, can you just repeat? I get it that you had prostate cancer. What were the treatments that you undertook?
Well, I had prostatectomy, and after the prostatectomy, I entered a clinical trial where I had IMRT radiation, 6 months of abiraterone, and scheduled for 2 years of ADT. But at a year, I told my RO how I was feeling because he asked. I didn't complain. I said, hey, it's not good, right? I mean, I work out like a Spartan, and I'm weak and fat, and I'm tired a lot, and I'm doing fine, and I'm perfectly willing to stick out 2 years. But my libido is shot, my erectile function is shot, and I'm having a great day. And he said, I think you should stop. I said, should I ask my MO the same thing? He said, absolutely. I asked him, he said, yeah, you should go ahead and stop. I even, at Rick's urging, got a second opinion at Fox Chase in Philadelphia. And they told me pretty much it's a data-free zone. We don't know. And I asked the college, and that second opinion, the question you really shouldn't ask was, if it were you, would you stop now or would you keep going? He said, I would stop now. So that was a lot of professionals telling me, and I did stop, and I recovered testosterone fairly quickly, full recovery in less than 6 months. And there was no Orgovix then. And that's what I did. And I had also, though, relentless incontinence. And I ended up getting an artificial urinary sphincter that solved that, but that was costly. And incontinence from surgery is not rare, I understand now. Not common either, but I had it real bad. And I can tell you, if you have heavy incontinence, you don't want that.
Right. And if you had to do it again, you'd skip the prostatectomy and just go right into the radiation.
Absolutely, I would have. Yes.
And this was 2020 timeframe.
Yeah. The surgery was in 19, and I finished it in 20, and by early 21, I was clear of all the testosterone suppression. But everything you know about, the brain fog, the fatigue, the hot flashes, none of it was that bad. But when you add it all up, especially my sex life changed forever. Fortunately, I have a very understanding wife. We have a great relationship. But the surgery is tough. Let's be honest. The size of your penis is less. The girth of your penis is less. The chances of you having erectile dysfunction are very high. And you're supposed to do your penile rehab, but in my case, I got on ADT almost right away, and my libido was completely zero. So the inspiration I had to do penile rehab was also zero. So I ignored it. Wouldn't have done that, but it wasn't easy. But here I am, having a great day again.
Sounds great. Thank you for sharing, Jimmy. And when I first got involved with this, after I was done and over with it and symptom-free after radiation, which was kind of almost a letdown how easy it was, we formed this group of people who had gone through the radiation here at UCLA called the Order of the Golden Walnut. And I had walnuts with little pins on it that I spray painted gold. And I thought everybody who I talked to online was going to get a golden walnut and a membership card that had all the websites they could go to get information. AnCan was the top of the list on that. And I started mailing these out only to find out that because it was over 3/4 of an inch thick, the post office was charging everybody $5 postage due, and no one got their walnuts, which is great. So you can be an official member, but you don't get a walnut. Stephen in Vancouver.
Hello, thank you. I'll try to be fairly quick. So I am in Canada, and that probably governs a lot of what I'm going to talk about. I was diagnosed almost 4 years ago with a 3+4 after a rising PSA, and subsequently a targeted biopsy, which showed the targeted area was a 3+4 and 20%, unfortunately, including a bit of cribiform and intraductal, another 3+4 and a 3+3. It's all on one side of the prostate. The one targeted area was initially a 0.6 millimeter. It's now grown to 12 millimeters, and the last MRI showed that it's now 6 millimeters abutting my prostate wall. So that became concern. Up to now I have been on active surveillance. I've been, taking lots of supplements, diet, and everything. But now it looks like I'm gonna have to get in gear and do some things. Unfortunately, I don't feel like I have a great support system with the medical, and so I'm reaching out to Mark Schultz there in LA. I've just completed his big package, and supposed to, just waiting to do the payment to enter into their sort of thing and have a discussion with him. I did talk with trade emails with Dr. Mark, and he said that I hadn't got a second opinion on my biopsy, so I reached out to Dr. Zui, and he thought I could just go down to pathology and fill out some forms. And when I talked with the pathology people, they said no. First person said, "Oh yes, somebody in the U.S. can order it," and then the second person said, "No, you have to go through your doctor here." and Dr. Zhui wasn't familiar with ordering it. So that's unfortunately a little bit on hold. I think I'll have to bring this up to Dr. Schultz about that. And my other one was that maybe I should get a PET PSMA scan with gallium. And again, I thought, well, I might as well just check with Dr. Schultz. I mean, I can get one in Vancouver here at a private clinic, or I can go overseas where I can get one for half the price. And does that make a difference? So now the thing about in Canada here is that when I talk, my oncologist is a medical oncologist, and all along I could just get very short conversations with him, and all along he's felt that I should get brachytherapy, and I've been hearing a lot about new different kinds of radiation, SBRT, Sabre, so on, and I don't know whether they're available in Vancouver or maybe there's other spots in Canada that they are available. I kind of feel like most people I talk to, we have limited sort of treatment options in Canada, and they just refer me to the kind of basic tried and true, the surgery or external or brachytherapy, and sounds like there are newer radiation ones, and it's just a question now of finding out if those might be better, and if so, are they available? So that's my story in a nutshell.
So, Stephen, we had talked, and I think you had said the fellow who does the brachy is very experienced in that. One of the biggest concerns is the experience, skill, and number of cases that the person doing brachy would do. The other concern would be, do you have disease outside the gland, which would not be ideal for brachy. I do know that all things equal with disease to the gland, at least in the past, Dr. Schultz has pushed people towards seeing Dr. Chang at UCLA and doing brachy. But I don't know what options. SABR and SBRT are the same thing, just how they're called.
Yeah.
George in Toronto, I wonder if you have any experience negotiating Canada's system that may help Stephen.
Is he still with us? Yes, he is.
Yeah, George in Toronto.
Are you there, George? He's probably stepped away. Yeah. Can we come back to him? I've also put an email in the chat. Just sent you an email to the chat, Stephen, for a gentleman called Joe Mingrone, who attends many of our groups and has done for years.
Yes, I was in touch with him just recently.
Okay.
Yes,
so
thank you.
He knows the ropes fairly well because he's tried. I can tell you it's difficult to get PSMA. I do not like the clinic that you're thinking of in Vancouver.
Initio.
Sorry?
It's called Initio.
Yes, I don't like them at all. That said, for a PSMA scan, it's fine. For treatment, I would tell you to stay well away from them. But for a PSMA scan, it's only a scan.
Well, there's a question. I mean, how much if it's a scan, can I go? Does it vary a lot for this kind of scan? In other words, I see that I can go to Cyprus and get one for half the price.
No, well, look, it's not the scan, it's who reads the scan. And so as long as you've got the scan and the results, you can find other people to read it, whether it's Schultz's office or someone else's office.
Yes.
But our issue with Initio is that they treated an elderly man who with curative lutetium who should never have been treated.
I see.
To make money. And
right. Okay.
And there's little we can do about it, but we say it, we call it as it is here. We don't like them.
Okay. Well, thank you. Good to know that.
You know, I mean, I won't get into more details, but
That's fine. That's fine.
but what happened was just wrong. He was a man who lived in Niagara Falls and flew out too many times and should never have been treated in the first place. But
Okay.
that didn't come into their reckoning. But yeah, I mean, did you say you were 4+3?
3+4.
Oh, you're 3+4. I mean, you know what?
Bulging membrane, though.
Oh, that's right. 3+4, but up against the wall. Yeah, you know, maybe a PSMA scan. They might give you one in the US, but they might not again as 3+4. But it's, you know, it's not a bad idea. And I think Joe's going to be pretty good. He's procrastinated for years. But it sounds like you do need now. What type of brachy was this? High dose or low dose?
Well, it's only low dose that's available. The high dose is offered as a trial basis.
Yeah, that's what I thought.
In other words, I would go in there and I wouldn't know if I was going to be signed up to low dose or high dose.
Yeah, that I had a had a feeling it was only low dose in Canada. I did low dose along with a lot of IMRT and hormone therapy. The low dose is an easy procedure. You get some urgency after it, but you always get urgency. I personally think at the time, well, I will say this, at the time it was probably the best option. Today, I think I lean more towards SBRT because you can do it in 5 sessions. But you know, low dose, you do it in a day, you're in, you're out, and if you're the right candidate, I think it works really well. It's good, especially if you have lesions that are close to the edge. It's not so good if you have lesions that are close to the urethra. But that's my own opinion.
Okay, well that's good. As if I understand it right, it's in the left mid lateral peripheral zone. The main tumor.
Is your prostate enlarged?
It's a little bit enlarged. I'm just trying to look for the thing. Maybe like 60 off the top of my head. Maybe.
So 60 is usually a cutoff that a lot of docs will use for the low dose. So that may kick you out of that. So when you talk to Scholes, make sure he knows about the size of the gland as well.
I've sent him the MRIs reports. So does the fact that it is abutting the prostate wall have any effect on the, say, a choice of a radiation treatment, or does it?
Well, I think that would depend on whether the disease is confined to the gland. So if the disease is confined to the gland, it's away from the urethra, something abutting the urethra, you may have a harder time with that. The brachy does involve an anesthetic. And if you had small grandkids, I'm not sure. Do you know, did they tell you, Rick, how long you needed to stay away from small kids?
Yeah, it's like three days. Although I can tell you, because it so happened at the time I was in a physical support group, and the leader happened to have a Geiger counter. And he brought it in, and we stuck that Geiger counter, and it went tick, 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 tick. And it did last quite a while. It probably lasted 3 months or 4 months or so.
Really?
Yes, but it slowed down significantly. It slowed down very tick, you know, but yes. But it's not it shouldn't be a big enough issue to, you know, nowadays we're treating with radionuclides and lutetium all the time, and the guys can't sleep in the same bed as their wives for 3 or 4 nights, and they get around it.
when you're traveling, you need to have a letter from the radiation oncologist, and I'm sure they will know about that because you will set off the radiation detectors at the airport if you're flying home, particularly across the border. You don't want them to say, hey, we have this radioactive guy here trying to get into the country.
Right.
Do we have your emails, Stephen? Are you signed up to get our reminders?
I'm going to check that. I'm going to make sure that I'm on the reminder so I can carry on here.
Okay, or you can just send it to me and I'll make sure that you're in there. But
Thank you.
coming back because we'll help you. We also happen to know Dr. Schultz very, very well.
Yeah.
So he is one of Dr. Mark's docs and has been for a long time.
Okay. Thank you, guys. Hopefully, maybe by next time I'll have met with Dr. Schultz. And
if you come down here and want to meet for lunch and you're spending some time, give me a shout.
Thank you.
Tim in Tampa, how are you doing? And do you have any questions for us?
Yes, I did want to just give an update. I had my first SBRT treatment today at Moffitt Cancer Center in Tampa. And my treatment will end on the 30th of October. I did have space ore on September 17th. And I've elected to go with space ore because Dr. Mark Scholes recommended it. And I think it was pretty much standard of care at Moffitt, although I had my mind made up. I didn't try and refuse it. And we'll see how that works. It's been generally good. Occasionally it feels like you're sitting on a golf ball, but hopefully it'll do its job. And I believe it's going to dissipate after 3 months. So I'll be another one of the SBRT guys. I'll leave it at that.
Did you have any hurricane issues?
Yeah, it's been terrible. A lot of trees, branches down, a little bit of damage to my house, but generally it could have been a lot worse.
And they didn't have to delay your treatment?
They did not, but it's been moving around because of the hurricane. It's constantly changing. But I should have it done all by the 30th.
Any issue or guidance on doing the prep with the bladder and the rectum where it's supposed to be for radiation?
Yeah, that's a lot easier than I've anticipated. The full bladder has been totally manageable for me. And as you know, Mark, the SBRTs are 18 or only 20 minutes. So, and I did use, I'm using the MRI Meridian tube. So they dealt with the claustrophobia issue with some special glasses that you look into and see landscapes so you don't know you're in a tube. And as far as bowel movement before the procedure, before the treatment, just take a laxative and make sure you have one. And it's been okay so far, but it's only been one treatment. And I did have the MRI simulation with Dr. Peter Johnstone, who I think you know.
Yeah, he's supposed to be the most experienced at Moffitt on this. I've had some people who've gone there and have been pushed away from MRI Linac to focal treatment. So I'm glad you're in with Johnstone.
Well, I'll keep you up to date. I'm curious to see what my side effects are going to be.
Bob S., did you have comments?
Question for Tim. What was your Gleason and all those numbers, Tim?
3 + 4, and I had Dr. Ming Zhao do one of my biopsy pathology reports. I had 3 pathology reports. He was one of them. 3+4, and my last PSA was 6.6. And I did have a PSMA PET scan, and it was favorable. No outside the gland spread. I had Decipher, low risk. I had prostox. Dr. Mark put that on my radar. And by the way, the prostox was not, I'm the only one and only prostox patient at Moffitt.
It really hasn't been adopted outside of UCLA. Patients who hear about it in groups can go and get it. They will do this outside. Again, my concern is that the initial studies with prostox basically cheek swab genetic tests to predict risk of long-term side effects from SBRT. And the issue was that the SBRT done in the initial study was done with CT guidance and had larger margins and no gating. So it's a totally different kind of scenario. Supposedly this year they're going to be coming out, or early next year, they'll be coming out with more data that will have more patients who've been on the MRI to show whether the risk issue is also present with MRI Linac as well as it was with CT Linac. Anything else for Tim?
The only thing I would like to say is, are you feeling less anxious and a little better? You seem to be, now that you've started treatment. I mean, we hope you are, but how are you doing? You seem to be a little more relaxed, Tim.
Well, you're very perceptive, Rick. Yes, I am a little bit now that I have a course I'm following, and I heard all the guys talk about anxiety and analysis paralysis, and because I've been there, I want to say that.
We'll vouch for that.
It's going to become boring in about 2 weeks. You're going to say, what is it with this prostate cancer stuff? Been there, done that. And what you'll be obligated to do is to talk and not be afraid to share your story with others so they get screened and, help other guys make decisions or come to decisions so that they can move forward.
Agreed. And I was in one other local support group just yesterday, and ironically, one of the doctors in there said, "Tim, it'll be boring." He said what you just said, Mark.
Yeah, that's how AnCan makes prostate cancer boring again.
Yeah.
You didn't care about it. You didn't care about it before, and our goal is for you not to care about it
afterwards. I just want to say one quick thing, because Captain Jim Marshall has been very good and very silent right the way through, and he's been sitting in here hoping that a friend of his might come in who he was going to support. But we haven't asked at all once in this meeting if we have any vets other than Richard in Maryland, if we have any vets present. And if we do have vets present, I'd love to recommend that you join the group that Captain Jim runs, which is not specifically for prostate cancer, but it's to help you get the most out of your veterans' health care and the most out of your benefits. And Boykin's here and Causley's here. We got a couple of other, we got a few guys who are in the vets group. It is a fantastic group. It puts your own VSOs to shame. So if you are a vet, you can either let me know in the chat or you can go on our website and sign up for the vets group. Did I say everything I was supposed to say, Captain Jim?
Absolutely. And the next meeting will be November 5th in the evening, that fateful day. So come join us at 8 o'clock within the Schmear room. And please sign up, because there'll be a reminder will be sent out that has a lot of good information in it each time.
Yes, yes. And just think, by the time you get done with Dr. Jim and the vets group, you'll be able to watch the results.
Yeah.
Yeah, that's the best part about being on the West Coast. Eric in Atlanta, you're going to have to stay up till God knows when to see when they come up with a decision in Georgia. I will get to just be finishing up dinner, turn on the TV, and I hope to God this is over by about 8 o'clock our time. We just have a few more minutes here, but Eric, I didn't get a chance to ask you, do you need some time tonight or have anything to bring up and share?
I did have I don't know if I told this group if I had my Artera AI test results done. And it's low risk. Because I'm in the low risk, they didn't even test for ADT if it would help me or not, because I'm below the threshold. But it's just another test that says I can wait, I guess.
Sounds great.
It's interesting, Eric, because I got an email today from Brad Power, who runs the cancer patient laboratory, I think he calls it. I always forget what he calls it. Cancer Labs, which presents, it's getting to be almost every week, maybe 2 or 3 times a month. They present speakers. And he wants to meet with me because they also have an incubator. And a lot of the people, and what they're finding is that several of their incubator people are not finding any traction with the pharmaceutical companies. So he wants to know, would people in our group be willing to entertain paying for some of these new technologies privately? And I don't know, I think of you because I know you're not on Medicare yet, thank goodness. So I don't know how available it was in your insurance and if you had to pay for Artera, but I'm not sure how to answer him, but I do know that we do have people in all of our groups who are willing to spring for some of these tests.
Yeah,
Do you have a sense, Rick, on why it's not available in California and New York?
Artera, no.
I did have to self-pay because my insurance would not cover it. But it was $285 to self-pay.
Right. Which is pretty reasonable. And I think a lot of times with these tests, that if you do offer to self-pay, you get pretty good rates.
Very.
And it's not the same rate that we see where they say, oh, it's X $1,000. Well, you say, yeah, but I'm paying out of pocket. Oh, okay.
Yeah, Decipher was the same. It was 300 and change. But they bill the insurance, of course, like $5,000.
Yeah.
It's a money grab, but for sure.
Yeah, I don't think that these guys are going to realistically be able to sell their products directly to patients at anything like the price that they think they can get if it's sold to insurers.
Right.
Well, when they bill the insurance $5,000, they still would feel really happy getting $600 or $700 out of it. Most of the time, the actual billing has nothing to do with the price that they're willing to accept. Certainly, that's the case with medications. We were talking earlier about Cleveland, and Dr. Spratt, who's at Case Western, is he's one of the developers and active people behind the development of the first stage, the AI, and how aggressive he was with the ADT part of the Artera development. So he's a good guy. Anybody else have anything else they want to share tonight? Okay, well, sounds like a great evening. Enjoyed speaking with everybody, and hope all is well. We'll see you here next month. We are on the second Monday.
Yes.
The second and fourth Monday again.
Back to normal.
Well,
right?
Let's hope it's back to normal and the election will be over.
Okay, we're not going there. We're not going there.
I don't have any predictions on anything. I just want it to be over.
Okay. All right, guys. Listen, thank you. Thank you, Dr. Mark. Thank you, everybody else. Hope you had a good experience. Good night.
Bye.